disorders, acquired disorders, or secondary disorders. So most common thing is secondary disorder. Among this, which is more common means, as you already know, HIV. HIV is a secondary immune disorder. So today let's see more of primary disorders. So what this immune system is made up of? Lymph nodes, spleen, bone marrow, etc. So how they work? So this immune system is basically of 4 types: humoral system, cellular immune system, and phagocytic and complement. Humoral means nothing but antibody protection. So B cells are responsible for antibody protections. So they mainly act against encapsulated organisms. And about the cellular immune system, T cells are involved. They act against viruses, fungi, protozoa, and mycobacteria. Phagocytes are nothing but neutrophils. They mainly act against fungus and bacteria like staph and pseudomonas. Complement system, they mainly act against bacteria. They have little role in other virus and fungus. So when coming to immune system, generally there is of 2 phenomena: innate immunity or adaptive immunity. Innate immunity is nothing but which is already present in the body. There is no need for prior sensitization. So whenever a pathogen enters into our body, there are certain cells which are already capable of tackling them, like phagocytes and dendritic cells, natural killer cells. In adaptive immunity, we have T cells and B cells. They take little time to act against those organisms. So innate immunity, they act faster within hours. Adaptive immunity takes time. Why they take time? Because they need prior sensitization. They have to, for example, this B lymphocytes, they have to transform into plasma cells where they produce antibodies, and these antibodies act against these microbes. Same way with T lymphocytes. They need to be presented with these antigens. APCs are nothing but antigen presenting cells like dendritic cells, macrophages, etc. So they will present the antigens to the T lymphocytes, and these T lymphocytes, they become effector T cells and they tackle these antigens. Then what is this primary response and secondary immune response? So this is basically with regard to humoral immune system. So primary response is, so whenever a new antigen enters the body, there is a time gap which we say is a lag phase. There's a time for this antigens to bind with these B cells, and B cells, they have to get transformed into plasma cells. And these plasma cells, they produce antibodies. So this is the first time this antigen enters into the body. So it takes some time for these B cells to produce antibodies. So mostly this antibody is of IgM type. When secondary immune, with regard to secondary immune response, since the B cells are already tuned or they are already exposed to this particular antigen, they take little time. So this antibody response will be faster, and the antibody type will be mainly of IgG type. So this what happens, this secondary immune response is responsible for tackling our common viral infections. So once we get chickenpox like in our childhood, we have a long-lasting immunity. So this is the example for secondary immune response. So how these immune components work? These B cells, as we already said, they differentiate into plasma cells. They help in opsonization, complement activation, toxin neutralization. T cells, helper T cells provide B cells with signals necessary for antibody protection. Cytotoxic T cells, they destroy viral infected cells and tumor cells. Another important function of these T cells is acting against autoimmunity. So T regulatory cells suppress autoreactive T cells. So whenever a problem with T cell in primary immune deficiency, there's a chance for autoimmune diseases as well. Phagocytes are neutrophils. They help in engulfing and destroying microbes. Complement system, they opsonize, and the terminal components, they create membrane attack complex. They will destroy those organisms. Natural killer cells, they mainly act against viral cells, viral infected cells, and tumor cells. So when do you suspect immune deficiency? So when there are recurrent infection in a particular child, and these infections are very severe with complications, and they attack multiple locations, and if you suspect unusual organisms which are more resistant to treatment, with a family history of similar illness in other siblings, so then we should suspect primary immune deficiency. So certain diseases like cystic fibrosis, congenital heart disease, they even present with multiple infections, but they don't infect multiple, those children, they usually respond to treatment. But with primary immune deficiency, response to treatment will be less, and there will be unusual organism, opportunistic infection. We don't expect opportunistic infection in a heart disease or cystic fibrosis, etc. So whenever you suspect a primary immune deficiency, you have to rule out other causes. That means the secondary other diseases which can cause recurrent infections. So to classify immune deficiency, primary and secondary. Primary is hereditary, secondary is acquired. Primary can be either B cell defect, that is antibody defect, or T cell defect, or cellular immune deficiency, or it can be combination of both T and B cell. It can be complement defect, phagocyte defect, disease of immune dysregulation. Secondary disorders are more common, like diabetes, HIV, undernutrition, cancer chemotherapy, steroid therapy, and prolonged illness. Critically ill patients, they will be having the secondary immune deficiency. So today we will see only about primary immune deficiency. So most common presenting symptom or feature is recurrent infections. As I said previously, non-immune related diseases like cystic fibrosis, celiac dyskinesia, tracheoesophageal fistula, they can even present with recurrent infections. So we have to rule out those things before investigating primary immune deficiency. So what is the special characteristic of primary immune deficiency? They present with autoimmunity as well, and as well as with some malignancies. So careful history and physical examinations will be of more help. So humoral immune deficiency, B cell deficiency, is the most common type, contributing almost 65%. So cellular immune deficiency is around 5%. Combined means both T cell and B cell involvement is about 15%. Neutrophil involvement is 10%. Complement diseases contribute around 5%. So what are the organisms? What are the type of infections which are common with these defects? So B cell defects, they mainly have bacterial infection and protozoal infection. T cell disorders, they have viral, fungal as well. So combination of T and B cell defects, they present with all these problems: bacterial, fungal, viral, protozoal. Complement disorders, they generally don't have any problem with viral, fungal infections. So main problem will be bacterial infections. Phagocyte disorders, bacterial and fungal. So how they present each defects? So T cell defects, they present early, even in the first month, second month of life. They why they are more dangerous means they present early in the even in the neonatal period, and compared to B cell, which takes around 5 to 7 months. T cell defects, they present early. B cell defects, they present late. The reason being maternally acquired antibodies. So babies have antibodies against certain diseases, certain organisms, which they acquired from their mother. Until these antibodies are cleared away from their blood, they don't be symptomatic. Once they are cleared of their antibodies, the babies will start giving symptoms. They start showing some features of immunodeficiency. So T cell defects, they present early. B cell defects, they present little late. Phagocyte defect, they can present early as well. Complement defect, they present late. So when regarding complement defect, so unless there is a inciting factor like trauma or any other infection or any inciting factor, this complement defect, they remain silent. So we are more worried about T cell, B cell and phagocyte defect. So to remember, B cell defects, they present after 6 months of age. T cell defect, they present early. So what are those signs for which we should suspect primary immune deficiency? 8 or more new ear infection within 1 year, 2 or more serious sinus infections within 1 year, 2 or more months on antibiotics with little effect, 2 or more pneumonias within 1 year, failure of an infant to gain weight and grow normally. This is what we call failure to thrive. Recurrent deep skin or organ abscesses, persistent thrush in mouth or elsewhere on skin after the age of 1, need for IV antibiotics to clear infection, 2 or more deep-seated infections, a family history of primary immune deficiency. So what are the symptoms and signs which directs us towards primary immune deficiency? So history, those warning signs which we said already. Another important thing is complication of vaccination. Primary immune deficiency mainly with T cells. The child becomes sick after giving vaccines, that too live vaccines. So this thing we don't see in any other diseases. So primary immune deficiencies, lot of vaccines are contraindicated. So you don't suspect primary immune deficiency in the first month or second month of life, but after giving vaccines, they become sick. So particular vaccine or live vaccine organism, they produce sepsis in that baby. So in those situations, we should suspect primary immune deficiency. So family history, early infant death, consanguinity, autoimmune diseases, or hematological malignancy. So these things should direct our path towards primary immune deficiency. So physical signs, as already told, poor growth, failure to thrive, absent lymph nodes or tonsils, skin lesions like abnormal hair or teeth, eczema, albinism, telangiectasias, petechiae, lupus-like rash, dermatomyositis, nail dystrophy, or ataxias, thrush, recurrent aphthous, dental crowding. These are some signs on physical examination which coincide with primary immune deficiency. So this one is taken from Nelson. So what are the clinical features of primary immune deficiency? So most common thing are recurrent infections, severe bacterial infections, persistent infections with incomplete or no response to therapy, and paucity of lymph nodes and tonsils. Absence of lymph nodes or tonsils in a child is nothing but primary immune deficiency. So no other disease will present like this. So other symptoms or other features: persistent sinusitis or mastocytitis, failure to thrive, skin lesions, diarrhea and malabsorption, hearing loss due to chronic otitis, bronchiectasis, evidence of autoimmunity. This is very important. Evidence of autoimmunity in a child. We should think of primary immune deficiency, that too T cell defects like autoimmune thrombocytopenia or hemolytic anemia, hematologic abnormalities like aplastic anemia, neutropenia, thrombocytopenia. So occasionally presenting features like lymphadenopathy, hepatosplenomegaly, which we get in many other diseases. So you have to correlate all these things: the family history, physical examination. And one more important thing in the neonatal period: delayed umbilical cord detachment. So this is an important point. It's common in phagocyte disorders, delayed umbilical cord detachment. So normally the umbilical cord, it will fall before 2 weeks. Even up to 3 weeks is considered normal. In certain books they say even 3 weeks is normal. But beyond that, if the umbilical cord fails to fall, definitely those children should be investigated. So what are the clinical manifestations with regard to each immune system? So B cell disorders, they present with recurrent bacterial cyanopulmonary infections, chronic or recurrent gastroenteritis, chronic enteroviral meningoencephalitis, and septic arthritis, bronchiectasis. T cell defects, they present with mainly fungal infection, severe or unusual viral infection, failure to thrive, chronic diarrhea, pneumocystis cerevisiae pneumonia. So this pneumocystis, they are opportunistic infections. So they are more common in secondary immune deficiency like AIDS. But after ruling out secondary immune deficiency, if you find this kind of rare and opportunistic infections, so we should suspect primary immune deficiency, that too T cell defects. Graft versus host disease. As I already told you, T cell defects, they can have autoimmunity as well as this graft versus host. This graft versus host disease is nothing but if the child is given blood transfusion or any of these lymphocytes present in the donor blood, they come and attack the host immune system. That's what we call graft versus host disease. So even a simple transfusion, the child will land up in serious problems. So regarding phagocytes, disease of neutrophils, they have present with skin abscess or lymphadenitis, bacterial pneumonia, infection with catalase positive organisms, poor wound healing, delayed separation of umbilical cord, chronic gingivitis, mucosal ulcers. Complement system, they present with recurrent Neisseria infection, pyogenic bacterial infection, autoimmune disease, and angioedema. So angioedema is particularly important regarding complement system. NK cell, they present with severe or recurrent herpes virus and HLH. So some more points regarding B cell. As I already told, it presents late after 6 months, recurrent infection with encapsulated organisms. So they have recurrent sinusitis, otitis media, pneumonia, meningitis, osteomyelitis. So T cell defects, they present early mainly with fungal infections, mycobacteria, viral infections, and opportunistic infection. Failed to thrive is more severe with regard to T cell immune deficiency. So as I told you already, this graft versus host disease, even they can present in utero with maternal fetal transfusion. So how to investigate? Lab workup. So common test we do is CBC. CBC is complete blood count and differential count. So most of the disease we can identify, we can suspect at least with the CBC and differential count. So with regard to B cell disorders, qualitative test CBC, immunoglobulin assay, and B cell number by flow cytometry. Quantitative tetanus, diphtheria, and pneumococcal titers. This is nothing but the titer of antibodies after giving this vaccination. If they have enough antibody titers for the commonly given vaccines, then B cell disorders are ruled out. Regarding to T cells, CBC with differential counts, flow cytometry, and to quantitate, we do T cell proliferation to mitogens antigens. With regard to phagocytes, quantitative tests, CBC with differential count, qualitative test, neutrophil oxidase burnt assay, or NBT. NBT is nitrous blue tetrasodium test. Complement system, individual complement components we can measure. Qualitative test, CH50 and AH50. NK cells, NK cell number by flow cytometry. Qualitative NK cell functional assay. So same thing. So absolute lymphocyte count. So normal count rules out most of the T cell disorders. If you suspect a B cell defect, first you have to do IgA. If IgA is normal, or so IgA is the first thing to do, because immunoglobulin A deficiency is the most common among all those immunoglobulins. If it is found to be abnormal, then we go for IgG and IgM. So screening test for phagocytes, absolute neutrophil count, respiratory burst assay. For complement system, CH50. CH50 is nothing but amount of complement activity present in the blood. That's what they say, CH50. So this one is taken from Nelson. So whenever you suspected immune deficiency, either primary or secondary, it's the algorithm to be followed. So you have seen what are the normal immune system, what are those components, and diseases of each component, how they present. So specific examples are specific diseases of each subtype. So B cell defects, we have IgA, selective IgA deficiency, common variable immune deficiency, X-linked A-gamma globulinemia. T cell defect, we have Biscott-Aldrich syndrome, Dye-George syndrome. So common to both, B and T cell affected diseases, severe combined immune deficiency, hyper IgM syndrome, hyper IgE syndrome. Phagocyte disorders, chronic granulomatous disease, cyclic neutropenia, leukocyte adhesion deficiency, Chitaki-Gazi syndrome. Complement disorders, examples, hereditary angioedema, and various complement component deficiencies. NK cell disorders, X-linked lymphoproliferative syndrome, primary HLH, and hemodeficiency. So let's see some important points regarding these specific diseases. SCID is severe combined immune deficiency, relatively common than other subtypes. So otherwise called Glanzmann-Rinker syndrome, bubble bowl disease, thymic A lymphoplasma. So main defect is absence of T cells. So impairment of both cellular and humoral response will be there. Specific defects in antigen presentation and functional immune molecules. Tonsils will be absent, lymph nodes will be small or absent. There will be lymphopenia, number of T cells will be reduced. Severe A gamma globulinemia. That means antibodies are not produced, so immunoglobulins will be absent. Types: autosomal recessive, X-linked recessive. Other important types: Naselov syndrome and SCID associated with ADA and PNP. ADA is nothing but adenosine deaminase. Next disease is Bruton's X-linked A gamma globulinemia. It's a primary B cell defect. Since it's X-linked, boys are more commonly affected. So gamma globulins will be severely reduced. So immunoglobulins, circulating immunoglobulins will be very much reduced, as well as marrow B cells. Selective IgA deficiency is the most common type of primary immune deficiency disease. So amount of immunoglobulin A will be drastically reduced. Dyeser syndrome, also called thymic hypoplasia. So defect is from the third and fourth pharyngeal pouches. So primary T cell defect. Other associated features: absence of parathyroid leads to tetany. There will be associated heart diseases. So specific therapy for Dyeser syndrome is thymic transplant. They have these characteristic faces, long faces. Ataxia telangiectasia, autosomal recessive. As their name suggests, there will be ataxias. Telangiectasia will be obvious over the eyes, ears. So recurrent infections. Thymus will be of fetal-like histological pattern. The picture showing telangiectasias. Scott-Aldrich syndrome, X-linked condition. Severe eczema, recurrent infection, blood-stained diarrhea, chronic otitis. So specific feature of Scott-Aldrich is small platelets, and they will be reduced in number as well. Chilaiditi, autosomal disorder. So main problem is large granules in the leukocytes leading to hypopigmentation, albinism, severe immune deficiency, neurological abnormalities, and bleeding tendencies. Chronic granulomatous disease, relatively rare disease, is inability of phagocytes to produce superoxide anion. So failure to express respiratory pulse associated with phagocytosis. Central necrosis, granulomatous response in lung, liver, bone, skin and lymph nodes, and presence of numerous pigmented macrophages. So the specific diseases, they are more confusing. So treatment wise, most of them will have common treatment. So what's the therapy for primary immune deficiency? Supportive treatment. So antibiotics. So whenever you have made a diagnosis of primary immune deficiency, you have to choose particular antibiotic with regard to cultures. So until cultures are available, blood cultures are first culture, we go for broad spectrum. When a specific organism is identified, you go for antibiotics based on culture and sensitivity. So in B cell defects, immunoglobulins are grossly reduced, so we give IV immunoglobulin infusions. Definitive therapy When there is thymus aplasia, we give thymic grafts. Bone marrow transplantation is the main treatment modality for most of these immune problems. Stem cell therapy and gene therapy. So finally, some important facts. So when you suspect immune deficiency, you look for these 3 important points: age of onset, type of organism, and family history. So T cells, they present below 6 months, and B cells after 5 to 6 months. Candidiasis, viral infection, recurrent diarrhea, T cell deficiency. Always look for lymphopenia. Absolute lymphocyte count less than 3000 in infancy is a very good clue to SCID, that is severe combined immune deficiency. Recurrent cytopulmonary infections, you go for serum immunoglobulins. A documented repeat pneumonia even a first life-threatening pneumonia, you do immunoglobulins. So rarely we go for immunoglobulin assay for a pneumonia case. So that's why we miss many cases of immune deficiency. So whenever there is a episode of life-threatening pneumonia, we should go for immunoglobulin assay. Persistent lymphadenopathy, liver abscess, perianal fistula, aspergillosis, and candida infections. So we should think of chronic granulomatous disease. Osteomyelitis involving small bones could be also a feature of chronic granulomatous disease. Horse faces skeletal problems, resistance of primary teeth. It suggests autosomal dominant type of hyper IgE syndrome. Though other immunoglobulins may be of higher in hyper IgE, they are non-functional, and regular intravenous immunoglobulin infusion is required. Petechial rash, atopic dermatitis, rash, and microthrombocytes, only one diagnosis, that is Viscott-Aldrich syndrome. Leukocytosis in the range of 1000 to 60,000, more than 90% polymorphs with no pus formation and with grotesque ulcers. Only diagnosis LAD. LAD is leukocyte adhesion defect. No itchy edema, recurrent abdomen pain. Do C4 level. It could be of hereditary angioedema. So common variable immune deficiency is a huge basket. Low immunoglobulins and normal B cell count could be a manifestation. They can even present in adults. Hyper IgM will have low immunoglobulins other than IgM. Blood transfusion don't interfere with assessment of T cells, but they could affect immunoglobulins. No live vaccination for T cell problems. Patient on IVIG don't need vaccines, but inactivated vaccines can be given, but immunity development will be an issue. So primary immune deficiency, though rare problem, most of the time the child dies before we make a diagnosis. So whenever we suspect a primary immune deficiency, we have to investigate so that they can be identified and promptly treated. So most of these primary immune deficiency disorders are lethal disorders. Unless we do a timely intervention, most of these patients will die. So I hope you guys understood a bit about primary immune deficiency. and thank you for your patience here. Thank you.